So Dr. Sallman, we know that stem cell transplant can be curative in MDS, but how effective is it? Is it the same expectations for every patient?
So again, I think this is where we've really come a long way to personalize sort of our discussions with our patients. I mean, in general, when we talk about long-term survival, we're talking about 50% of patients. But again, this can be different, again, based on their disease. And there's really two things we look at. One, what is their disease status at the time? And then specifically, what are the drivers of the disease? So as far as the disease status, we really optimally would like these patients to be in as good a remission as possible. So we like to see no circulating blasts. We like to see blasts in the bone marrow to be less than 5%. And ideally, would have good blood counts. And this is from a factor we know that the better the patient's disease is, the better the chance of long-term survival from transplant. But also I think this improves their functional status. We know that transplant's a long road. There can be many side effects with it, so patients that go into it healthier may do better from that standpoint as well. I think more importantly, again, we're looking into, again, the patient's personal disease, and really mutations, again, are the most important. So for example, TP53, which is really the worst of all mutations, when we've looked at all the transplant literature to date, is really the one mutation that predicts for a very low cure rate to transplant. And really these patients need novel therapies, clinical trials, both before transplant, maybe during transplant and after transplant, again, in order to improve their chance. We think that potentially the more mutations patient has, again, the higher risk that they may relapse or not be cured from transplant. And again, in the end, this is our only curative treatment, so we still are largely supportive of that, but it's just important for patients to have realistic expectations of their chance of cure. I think also in this setting, we are thinking about, is there something we can do after transplant? So let's take a patient who may have a higher risk for the disease to come back. We may recommend potentially a trial. For example, our hypomethylating agents, again, are being considered in multiple trials after transplant, again, with the goal of hoping to prevent the chances of relapse. But again, mutations in the disease biology or their disease status is really what overall influences the chances of a patient being cured from MDS.
Can you tell me, after the transplant, whether it's 100 days or 6 months later, and you repeat a bone marrow and you start to find some signs that the MDS is coming back, does that mean that all hope is gone? Or are there things you can do then to really regain that response? And if someone who has profound progression of the disease, is a second transplant possible?
These are good questions, and I think we're always very concerned at any time if really there's any evidence of the disease coming back. So, one thing we follow on these patients is something called donor chimerism. So basically all that means is what percentage of the donor is the patient. We would like them to be 100% both in their blood as well as in their bone marrow. But sometimes this can be lost, and this can be an early sign that the patient's bone marrow or the patient's disease is going back. So sometimes what we can consider is a donor lymphocyte infusion, or DLI, which is basically giving another infusion of the same patient's stem cells in order to regain that response. And there are cases where patients have been cured and have had long-term survival from that, although the rate of long-term survival with DLI is relatively low. I would say overall the chances of getting a second transplant are very uncommon. One would be the overall age of the patient population, and just the risk is really too high, although these things can be considered. I think, again, we do think about clinical trials in this setting. We think about immune therapies, again, therapies that may sort of return on the immune system or return on the patient's donor graft to potentially get these patients back in remission. But it's definitely a patient group that we think about trial. There are a couple of standards that can consider, but again, we have a lot of concern in this setting.
Is there a role for hypomethylating agents after transplant?
We know that giving hypomethylating agents after transplant is at least safe. And if we compare patients who, let's say, have had up to 1 year of hypomethylating agent, and we look at their chances of relapse versus, let's say, historical control, it appears that potentially it's better as far as preventing, but really we need really better trials to truly define, because it is putting patients through additional months of therapy. We really want to know, is this improving their chances of cure or not? We do sometimes, again, consider, let's say if a patient was never resistant or refractory, we may be able to get patients have a good response to hypomethylating agents after transplant. In that setting, it would be often continued indefinitely, as we do for other MDS patients once we start hypomethylating agents. But that would be more in the setting if the disease truly came back.